Good evening, everyone, and thank you for joining us to learn more about PKD in children. As you know, PKD is a genetic disease, and so we're also going to be talking about PKD genes and how they work. I'm Nicole Haar, Director of Community Engagement at the PKD Foundation, and I will be your host this evening. We will get started with the presentation in just a moment, but first, I have a few announcements. Please note that the PKD Foundation does not offer medical advice, and the information shared this evening is not intended to be a substitute for consultations with your healthcare team. Care and treatment decisions related to your health must be made in consultation with your health professional team. All attendees will be muted throughout the presentation to ensure good audio quality for all of our viewers. We are recording this webinar and will archive the recording on our website within the next few days. If you have any questions during the presentation, please type your questions into the question box located in your control panel on the right side of your screen. We will do our best to answer as many questions as possible during the Q&A session immediately following the presentation. Please note we will address questions related to the webinar topic. If you have specific medical questions, please follow up with your healthcare team. I am delighted to introduce you to our speaker this evening, Dr. Lisa Guay-Woodford. Dr. Guay-Woodford is a pediatric nephrologist and an internationally recognized investigator whose research focuses on identifying clinical and genetic factors involved in the pathogenesis of inherited renal disorders, most notably autosomal recessive polycystic kidney disease. He is currently the Richard L. Hudson Professor of Pediatrics and the Associate Vice President for Clinical and Translational Research at the George Washington University and the Director of the Center for Translational Science at Children's National Medical Center and Director of the Clinical and Translational Science Institute at Children's National. Dr. Guay-Woodford is currently serving as an advisor to the PKD Foundation's PKD in Children Council. She has volunteered her time in many capacities, including serving on our Board of Trustees, presenting at national conferences, and assisting with the development of patient resources, and much, much more. And I am very grateful to have her with us tonight to present on such an important topic. So Dr. Guay-Woodford, I am going to turn this over to you. There you go.
Great, Nicole, thank you. So good evening, everyone, and it's really a pleasure to have the opportunity to present this topic. As Nicole said, PKD is a genetic disorder, and I'm going to really focus on the manifestations of this genetic disorder or set of disorders in children, talking about the clinical features of the disease, the genes that are disrupted, how we make the diagnosis, and how we think about improving therapy for all of our affected children. So let's see if I can advance this. Here we go. So I am a consultant for Otsuka Pharmaceuticals, and so that's a relevant disclosure. What I'd like to do in the next 50 minutes or so is to briefly give an overview of what PKD is, to talk about the key issues in children in terms of autosomal dominant polycystic kidney disease, or ADPKD, and then switch gears and talk about key issues in children with the recessive form of polycystic kidney disease, or ARPKD. And then to close out the talk, to talk about what goes wrong in PKD, both in terms of the PKD genes and their proteins and the pathways that these proteins operate in, because understanding that framework gives us entry points for targeted therapies that can slow the rate of progression of the disease. So let's start with just a brief overview about PKD. And to understand PKD, we need to understand what the normal kidney is. So the kidneys are a pair of reddish brown organs. If you've had chili, they look very much like the beans that are in chili beans. They're located on either side of the spine, just below the diaphragm, in the back. So they're behind the liver, behind the stomach. And in people without any kidney disease, they're about the size of one's fist. The primary function of the kidneys is to remove waste from the body through the production of urine. They also help to regulate blood pressure, blood volume, and the chemical or electrolyte composition of the blood. And so shown, let's go forward. Shown here and I guess the pointer doesn't work. Shown at the top left-hand corner is where the kidneys sit in the body, and in the lower panel, it is a section through the kidney that that shows you the functioning unit of the kidney, which is called the nephron. It kind of looks like a curled-up garden hose, with the nozzle being the glomerulus, where the filtration of blood occurs, and then this long, very complex tubule that is really not a garden hose at all. It's a very smart system that measures what the body needs in terms of getting rid of excess water and salt and waste products, and holding on, when necessary, to water and salt, so that it maintains a normal balance of the body as a whole. So how do the kidneys maintain health? Well, as I mentioned, it serves kind of as the washer and dryer of the body, removing waste and excess fluid through the production of urine. It continuously monitors and regulates body fluids and chemical composition, removes also many drugs, not all drugs, but many drugs and toxins from the body, and it produces and releases hormones into your blood. So critical hormones that are important in making red blood cells, in regulating blood pressure, and in helping the intestine absorb calcium from the diet, and thereby maintaining healthy bones. In terms of the kidney handling salt and water, I like this figure because it shows that an enormous amount of salt and water are filtered through every one of these filtering units in the kidney. But very little is actually let go from the body, because it is really dictated by what the body needs to maintain a normal balance of salt and water. So the kidney is a really very, very smart organ when it's working well. In terms of the liver is actually one of the largest and most complex organs in the body, weighs about a pound in an adult, and is made up of a spongy mass of wedge-shaped lobes. And that's shown in the upper left-hand corner on the slide. The liver has a lot of functions that are necessary for life. So it helps process carbohydrate, fats, and proteins that are absorbed from food in the intestine, and then turns them into building blocks that the body needs to build, for example, proteins, and maintain the normal integrity of the cells of the body. It secretes bile to help digest fats. It makes factors that are needed for clotting. It stores vitamins, and it breaks down toxic substances and drugs that it removes from the bloodstream. In the lower portion of the slide, the normal liver is shown in cross-section, and the brick red color is the major component of the liver. Those are called the hepatocytes. But what I really want to point your attention to is sort of the light brown colored structures. That is what's called the portal triad, and it's made up of bile ducts, and in the center of those bile ducts is the portal vein. And it's that structure in the liver, or those structures in the liver, that are impacted by polycystic kidney disease, as we'll talk about in a minute. So I mentioned that this was a genetic disease, and so I thought this cartoon would help us understand genes. So genes in the body are organized on chromosomes, which you can think of as being stacks, genes being coins, and they're stacked in a very sort of organized relationship, such that you have 2 copies of every chromosome and 2 copies of every gene. And so the arrow points to a gene that would be a PKD gene. The abnormal copy is in red, and the normal gene is in blue. And so in a dominant disorder, the problem is that 1 copy of that gene is defective or is disease-causing. In the classic form of dominant disease, that abnormal copy is transmitted from one generation to another, in this case from the father to the affected boy. Now, what genes do is they make proteins, and the way that they do this is that they are really like sort of a string of blocks, like our children play with, that are put together in different arrangements, and that string is what we think of as a protein. And when you have a defect in a gene, that string, that protein, either doesn't form normally or has a defect in its formation such that it doesn't function. In the recessive form of the disease, again, you have 1 abnormal copy in the father, but in this case, the father is unaffected. And you have another abnormal copy of the same gene in the mother. the affected little boy has inherited one copy from his mother and one copy from his father, whereas his unaffected sister either only got one abnormal copy or got both copies of the normal gene from her parents. So a recessive disorder, you need two abnormal copies of the gene. In a dominant disorder, one abnormal copy of the gene. So what is polycystic kidney disease? Well, it is a disorder that primarily affects, particularly in children, the kidney and the liver. And the issue really depends on what gene is disrupted. So let's now turn our attention to the different forms of polycystic kidney disease and talk about the clinical manifestations. So in children who have the dominant form of the disease, typically there's a family history. And so this is a pretty common disorder. The prevalence that is estimated in the world's population is about 1 in 800 to 1 in 1,000. There are, to put it another way, about 10 million persons worldwide in all ethnic groups that are affected with ADPKD. And it's estimated about 600,000 individuals in the United States. In terms of the molecular genetics or the genetic cause of PKD, defects in one of two principal genes, PKD1 or PKD2, cause the lion's share of disease in the population. There are now at least 3 other genes that have been identified as causing ADPKD. The most common one of those is a gene called GANAB, but this gene and the other genes account for less than 1% of affected individuals. So let's really focus on the 2 major genes, PKD1 and PKD2. For children and adults who have ADPKD due to mutations in, say, PKD1 or PKD2, only about 1 to 2% of the nephrons, and that's shown in the middle panel, are affected. And by affected, what I mean is that they have these soap bubble-like cysts that bud off the continuity of the tube. But it's only about 1 to 2% of the nephrons that have this abnormality. And so in a sense, these cysts sort of serve kind of like a rotten apple in a basket. Most of the apples in that basket start out perfectly fine, but over time, that rotten apple can actually spoil the entire basket. And so that's kind of the concept to think about with ADPKD. The process of those cysts growing in size can cause the kidneys that start out normally with just a few cysts to become extremely large with the cystic burden that develops. In addition to the kidney, there are other associations. These are primarily seen in adults, although on imaging studies, you can see biliary cysts or cysts in the liver in those bile duct structures that we talked about, particularly in adolescents. Sometimes you can see pancreatic cysts, but these are clinically not typically very significant. There are issues in structures outside of ductal structures, like in the vascular system. Perhaps the most feared consequence of ADPKD is aneurysms that affect the blood vessels of the brain that can rupture and lead to strokes. There are issues for particularly males having hernias, and in some males actually even having infertility. When we think about ADPKD, I think it's important for us when we're considering children to think about age-related manifestations. And so here, ADPKD can be thought of in 3 major groups. There's early onset ADPKD, where children are diagnosed in utero or at the time of birth with clinically significant disease. For those children, the disease is primarily confined to the kidney, and can be a very aggressive form of kidney disease, with about 25% of these children losing their kidney function during childhood, so before they reach adulthood. In typical childhood onset, so this is not just a child who's diagnosed with ADPKD who's completely well and ends up in an ultrasound suite on a Saturday morning because their parents want to know, do they have cysts? This is a child who comes to medical attention because they have blood or protein in the urine, they have high blood pressure, occasionally they can even have kidney stones, or in little boys, they have a higher rate of inguinal hernias. these are symptomatic children. And these children tend to have a much slower rate of progression of their disease. And then there's the typical adult onset of this disorder, coming to medical attention in late teenage years or through their person's 20s or 30s. These patients typically have kidney disease, but they can have the more systemic manifestations of the disease, including biliary cysts, heart valve problems, in a subset of these patients, even intracranial aneurysms. When we think about management, I think one of the things that is really important to point out is by and large, all of our information about disease management comes from adult studies. So we know that hypertension is a major issue in this disorder, and can be a progression factor for disease. In other words, having uncontrolled high blood pressure can accelerate the rate of progression for the disease. And we know about the best forms of therapy in adults. When we ask the question about what's the best way to take care of children who have hypertension, we have to look at really very small studies that have been done to date. And for these studies, it pretty much bears out that using an ACE inhibitor or an ARB as first-line therapy is an appropriate way to proceed. What we don't know, though, is what is the best target blood pressure, because these studies have been very small. So for those of you who have ADPKD in your family, you know in adults there's a discussion about aggressive control of blood pressure or controlling blood pressure so it's just in the normal range. In children, we don't know the answer to that. More studies have to be done, more children have to be studied. Abdominal pain, major problem in both children and adults. It can be a sudden onset or acute onset due to a cyst having a hemorrhage, an infection, or a stone, or it can be a chronic pain that children live with because of the size of their kidneys and the cystic burden. These cysts can rupture, and you can see this blood in the urine. Typically, it resolves in 2 to 7 days, but can be very frightening for children who experience this. Stone disease can cause both pain and blood in the urine. We use sort of standard approaches, but again, these are standard approaches that we have learned from adults. Cyst infection, very special class of antibiotics that we want to use because we want those antibiotics to get into the cyst specifically and deal with the infection. Obviously, if a child develops end-stage kidney disease, transplantation is a preferred option in children, even more so than in adults. But this is not a typically common problem for children with ADPKD, the caveat being those children with very early onset ADPKD. And kidney cancer, or renal cell carcinoma, is really not an issue that we see in children, and in fact, it's a very rare complication in adults. The one thing that I really want to point our attention to is some beautiful work that has been done by investigators in the CRISP study and the HALT study, and in some of the therapeutic studies have demonstrated that the total size of the kidney, or the total volume, is a very important marker of who has more disease or less, more severe disease or less severe disease. And in fact, there is a classification system that has been developed by folks at the Mayo Clinic. There are other classification systems that have been developed to say, if you have mild disease, 1A disease, your disease course is probably going to be pretty slow. Whereas if you have very significant disease, then your disease course is probably going to be faster. But these criteria only apply to the adult population, and we don't have information about this kind of prognostic marker in children with ADPKD. So if we switch gears and talk about the recessive form of the disease, this is a much less common disease. The incidence that we've calculated doing a large medical record study is about 1 in 26,000. The molecular genetics overwhelmingly point to a single gene, PKHD1. The kidney disease is very different than what you see in ADPKD. This isn't soap bubbles. It's kind of like the garden hose in the Looney Tune cartoons, where the garden hose just dilates. And that dilated structure that you see in the cartoon on this image is primarily in the last part of the nephron, what we call the collecting duct. And then there are very few other associated features in ARPKD, both in children and in adults. And those features primarily, again, involve the biliary system of the liver. So here's another representation, the normal nephron, that's the functioning unit of the kidneys shown in the panel marked A. The cyst formation in the recessive form of the disease, the dilation of that collecting duct, and it leads to kidneys that when they're cut in half, look big and very spongy. In the liver, the problem is really a developmental abnormality. In the left-hand panel, the structure in the middle is the portal vein, and it is surrounded in normal development by a beautiful lattice work of really well-organized bile ducts. In ARPKD, something goes wrong with that patterning. The portal vein is not normal in its structure, and the bile ducts that surround it are very chaotic. In the middle panel is a section through a liver of a child with ARPKD, and what you can see, those sort of open spaces that look like lakes, those are the bile ducts, and that's really abnormal. And the darker substance around it, that's actually scar tissue that seems to be prompted to form by this developmental abnormality. And as a consequence, in the cartoon on the far right, blood coming from the intestines back into the liver, bringing all the nutrients to be processed by the liver. That blood is in veins that, with the scarring around the portal vein, that pressure in that venous system can go up. And so the blood can actually then find an easier route to travel, going to the spleen, going to the veins around the esophagus and the stomach. And those can become very swollen and dilated, what we recognize clinically as varices. So if we think about what happens to patients with ARPKD, for those of you who go to the Google to get your information, you will see pretty dismal findings. And in fact, ARPKD does have a significant patient mortality in the newborn period. Again, from our studies, we estimated to be about 21% of patients with ARPKD die in the newborn period. The next mortal event, though, is really very late, well into adulthood. So if a child survives the newborn period, typically they survive through the course of childhood. That's the major take-home message from this slide. And if you think about their kidney survival, this is a very complicated slide, but let me just sort of briefly take you through it. On the left-hand side, what the data show is that at 5 years of age, about 86% of kidneys are functioning in ARPKD patients. At 10 years of age, about 71% of patients have functioning kidneys. Now, they may not be perfect, but they're functioning. At 15 years of age, it's about 66%. And at 20 years of age, on the threshold of adulthood, about 42% of patients have functioning kidneys. And that's borne out by a much smaller study at the Mayo Clinic, which got about exactly the same percentage of renal survival. So at 10 years of age, about 75% of kids have functioning kidneys, and at 15 years of age, about 50% of kids have functioning kidneys. So again, the take-home message, this is not a uniformly lethal disease. There is a high rate of mortality, primarily in the newborn period. For those children who survive, they survive through childhood. And even their kidneys, for a large percentage of them, continue to function so that they don't need dialysis or transplantation in childhood. So when we put this all together with ARPKD, many of these kids are diagnosed in the newborn period. This is data from 2 different studies that were done in the early 2000s. Many of these kids, but not all of them, have troubles with low sodium. And this isn't because they have a total body depletion of sodium. It's that their kidneys, because they're not functioning properly, actually can't get rid of the extra water. So they're diluting out their sodium. And that's important because some of these kids stay on sodium for a long period of time, even when they have terrible problems with high blood pressure. So we really got to think about what the problems are and the best way to address the issues that we're seeing. Urinary tract infection is common in these children. Not all of them, but about 25% have urinary tract infection. We talked about kidney survival. Growth issues can be a problem in these children, at least in 2 different studies. chronic lung disease, because these children can have issues in terms of lung development. And I can address that in the question period if folks are interested. The portal hypertension we talked about is a common feature, but not a universal feature. And perhaps most importantly, the survival. This is not a uniformly lethal disease. If we take this in terms of age groups, in ARPKD, the issues in newborns are poor lung development, leading to a mortality rate of about 21%. Typically, this occurs in the first few days of life. In terms of the kidney, problems with low levels of salt in the blood. Again, that seems to be a problem primarily of the kidney not being able to get rid of the extra water, so the salt level gets diluted. Decreased kidney function can be an issue even in newborns, very large kidneys, and high blood pressure. These are the problems that you primarily see in newborns. In older infants and children, the issues again can be poor lung development, leading for a subset of children to chronic lung disease, electrolyte abnormalities, high blood pressure, and declining kidney function. The liver issues can come into play with portal hypertension, leading to varices and variceal bleeding, as we discussed. And those dilated bile ducts are particularly susceptible, at least in a subset of these kids, to getting infected, an infection that we call cholangitis, which really requires a good level of clinical suspicion for a child with ARPKD who comes to medical attention with a fever and really not looking like they're feeling very well. Feeding issues can be a major issue for particular infants with ARPKD, and sometimes we address that issue by placing feeding tubes to be sure that these kids get enough nutrition. And then there are recent reports that intracranial aneurysms, again, not common at all, but can be can be observed in a small subset of patients with ARPKD, just like intracranial aneurysms can be seen in a subset of patients with ADPKD. The mechanisms, are they the same? We don't know the answer to that, partly because at least in ARPKD, these aneurysms are so rare. So what goes wrong in PKD? Well, let's think first about the genes and the proteins that they encode, and then we'll finish up thinking about the pathways that these proteins operate in, or thinking about the genes, the proteins being the players, and then the teams these players operate on. Okay, so in terms of thinking about we talked about what the genes are in the forms of polycystic kidney disease. And for a very long time, we would look at these genes gene by gene in terms of genetic testing. But the problem is that in a very large study, that mutations were only identified looking at these two genes, PKD1 and PKD2, in about 90% of patients. So the idea was, well, what's going on in this other 10%? And in this other 10%, about 3% were found to have mutations in a third gene. And then as folks looked more and more, there was a fourth gene and a fifth gene. So looking gene by gene basically is like looking for lost keys under a street lamp. You only see where the light shows you. And so if the keys are outside the cone of light, you won't see them. So we need perhaps a different approach in ADPKD. And that's really true in ARPKD, because there are a lot of ARPKD lookalikes. An early manifestation of ADPKD can look for all the world like ARPKD. Mutations in a gene called HNF1 beta, or in two other genes that are involved in a different cystic kidney disease, can look for all the world like ARPKD. And in fact, this slide really shows you the complexity. There are a whole series of disorders here, 7 of perhaps 12 disorders, a variety of genes that can be disrupted in each of these disorders, probably totaling well over 100 genes that could be involved. And there are patients who can have mutations in any one of the genes shown on this slide that can look like ARPKD due to mutations in PKHD1. So how can we use genetic analysis to make the diagnosis of what is going on in a patient? And here, what is becoming very much the standard approach is to use gene panels. And the way that this works is one actually looks at the sequence for every one of those little blocks shown in the upper panel. So it's all of the coding regions for all of the genes. And then one applies very special lenses or informatics tools to focus on a specific set of genes. And that's where you get your gene panel. The benefits are earlier diagnosis. You're not having a diagnostic odyssey with a whole lot of unnecessary tests. And you give the disease a name because you know what gene is disrupted. It can alert clinicians to associated issues. So is it ARPKD? We need to think about this issue. Or is it an ARPKD lookalike? And we need to think about a different set of issues. It enables informed genetic counseling and assessing the recurrence risk for future children. And then that includes prenatal testing and pre-implantation genetic diagnosis. So you select an egg that is a fertilized egg that is not carrying 2 copies of the abnormal gene. And in the future, genetic testing may guide personalized medical management on a gene-specific basis, the so-called precision medicine concept. So when I suspect a patient has ARPKD, I don't order just a PKHD1 test. I, in fact, order a gene panel, and I want to specifically look at PKD1, HNF1 beta, and some of the other genes that are shown here, just to try to get a comprehensive first-pass look at what might be going on in a given patient. So, as I mentioned, genes encode proteins. That stretch of genetic material encodes a protein, and it's the protein, if you will, that's the player on the baseball team. And so this schema shows 3 schematic representations of the 3 major proteins involved in PKD, polycystin 1 and polycystin 2 in the dominant form of PKD, and FPC, which is the protein encoded by PKHD1. And so this is all very interesting, and for someone like me, it gets me very, very excited. But even more exciting than this kind of schema for me is baseball. And I use this to sort of say, genes don't play singles tennis. They play on a team. They operate in pathways. And that's important in terms of understanding everything from disease severity. So how well a given player on the team plays, how much they may be damaged by, for example, an injury, is important. If the pitcher is the disease gene, it's important how healthy he is and how well he can play. But how his team does depends not just on him, depends on the other folks on the team and how strong they are or how weak they might be. And that all figures in to how well the pathway, the team functions. And so I think it's important because understanding those pathways is really critical to understanding how we might intervene in this set of disorders. In baseball, you can replace the pitcher and the team can all of a sudden get better. But gene therapy for these kinds of diseases is not really an option on the near term. So understanding the pathways might give us entry points for targeted therapies that really can affect the course of the disease. And so here, if we think about the panel on the left-hand side, this is the schema of a cell. You've heard, many of you, a lot about the cilium, which is kind of the antenna of the cell, sensing what's going on outside. And it feeds into the cell and a network of processes that the cell depends on for its normal function, or when those processes go awry, for disease expression. When we think about polycystic kidney disease, one of the things that we know is that factor called cyclic AMP is really driven up in polycystic kidney disease. And driving up cyclic AMP causes a malfunction of the different circuits in the cell. One of the things that can happen is that it changes the characteristics of the cells such that fluid can get pumped in to those abnormal cystic structures, causing them to get bigger and bigger and bigger. So it changes the normal regulation of the network of receptors and channels and regulators, much like disrupting a sluice gate could lead to flooding in a place that is prone to flooding near a river. In terms of thinking about other pathways, another major abnormality in PKD is that cells multiply too much. They're not checked into keeping a certain number, and that's called proliferation. And there is a circuit of regulatory pathways. So for those of you who like to entertain your kids with educational tools, there's these snap circuit toys that allow you to sort of think about simple circuits. Well, in many ways, the cell is a circuit of regulatory pathways. And this abnormality of driving up cyclic AMP can drive those circuits that lead to the cell multiplying too much, proliferating too much, adding to the cellular contribution of these ever-expanding cysts. Now, I keep circling that structure called V2R at the bottom of the slide. And the reason for that is because understanding these circuits, so I've kind of turned the cell 90 degrees counterclockwise, understanding the circuits that go awry in a cell is very important to kind of think about drugs that might put it back in balance. And so if we think about the V2 receptor, that's driving that production of cyclic AMP. But we have drugs that can sort of serve as a brake on that receptor, and so tamp down the cell's production of cyclic AMP. And all the processes, the secretion of fluid into cysts, the proliferation, can be tamped down. That's a good targeted therapy for PKD. Most studies that have looked at this drug have looked at it in ADPKD. But for many of these cystic diseases, the biology is common. So it is possible that this kind of drug would be useful in ARPKD and other renal cystic diseases. That's the subject of future studies. There are drugs that can actually act on a different receptor. And this receptor by itself, it has a built-in mechanism to put a brake on cyclic AMP. So in a sense, what you want to do therapeutically is rev up this receptor so that that brake works more effectively. There are drugs that can block the secretion of fluid through the channels on the urine-facing side or the cyst-facing side of the cell. And some of you have heard of or have participated in studies with an agent called tesivitinib, that is a drug that can block the pathway that's responsible for cell proliferation. So putting all of this together, I think what I'm trying to do is to demonstrate to you that understanding these different circuits in the cell, how they interact, where there are entry points for specific drugs that can change the abnormalities in these pathways, can lead to a less severe form of the disease. And in a sense, this is a form of precision medicine. The idea here for all of these therapies, it's not we're going to correct the basic defect. It's to minimize the chance that any given patient, particularly any child, feels the full consequences of PKD. Okay, so this opens up the idea about clinical studies or clinical trials. And in fact, there are a number of clinical trials. And for those of you who are interested in clinical trials, you can find all the clinical trials that are being conducted in the United States, whether those clinical trials are conducted or have been initiated by an American investigator, or they're part of an international study. I think that the thing that is most important for us to realize is that the clinical trials that are being done in PKD require that we have markers that predict what the disease course would be. Because the idea is that you want to change the curve of the disease course and make it less severe. So you have to have a way to measure it. We don't have those markers for ARPKD or many of the other recessive cystic diseases that I showed you in the, that table a few slides back. We do have markers like total kidney volume in ADPKD, but we don't know how to use that marker in children. And so even in ADPKD, there are very few studies that are enrolling children to look to see the efficacy of these targeted therapies that affect pathways. And that is, I think, a major area of focus for those of us who are interested in advancing our understanding of PKD in children. How do we assemble a large enough cohort of children with markers of disease that we can measure the effectiveness of a given agent and look to bring to the clinic drugs that are more precise and specific than just controlling blood pressure or controlling protein in the urine. So if one looks at clinical trials for polycystic kidney disease in adults, there are 27 studies that are recruiting interventional trials in adults 18 to 64 across the world. If one looks about interventional trials in children 0 to 17 years of age, there are only 2 studies internationally, only 1 in the United States, and there's only 1 in ARPKD. So again, we don't know if the diseases are exactly the same in their manifestations in childhood, and we don't know if some of the drugs that are being developed for clinical use in adults will have the same kind of efficacy, the same kind of safety in children. So a very open area for investigation. One thing that's very important, so those of you who are regular recipients of messages from the PKD Foundation know that the ADPKD registry was just launched on September 4th, and that's really very important. One thing that we are doing here in Washington is establishing ourselves as the US and perhaps Canadian node for a global study on ADPKD in children. In addition, we have developed an ARPKD database that now takes into consideration or accepts children with ARPKD and a whole variety of other recessive Hepato-Renal fibrocystic diseases. We built a database, and we actually shared the backbone of that database with our European colleagues and our UK colleagues. And in addition, we have exported our database to a number of countries around the world. The idea here is disease in children by definition is rare. Polycystic kidney diseases in children are rare. To really advance our understanding, we need to collect information from a large number of patients, and the best way for us to do that is for us to collaborate and cooperate with centers across the United States and around the world to pull together large numbers of patients where we can understand their clinical manifestations and have them be, if you will, a research-ready cohort that we could think about who would be the best group of patients from this cohort to be studied in a given clinical trial. So this is our website for our ARPKD database. The PKD Foundation has been terrific in promoting this. I'm sure lots of you have seen this before. This is our flyer about a child with renal cystic disease, how you could go about enrolling your child, and we'll have a flyer like this about enrolling your child with ADPKD. The study is just in its final stages of approval by our ethics board or our IRB. So let me just summarize by saying that PKD is a clinically significant disorder in children, and it's a disorder that we don't know in a fundamental way very much about it. Most of our knowledge comes from relatively small studies in relatively limited numbers of children. So much more needs to be done to advance our understanding. In terms of thinking about diagnostic strategies, they're improving, particularly with new genetic tools like gene panels. And while the polycystic kidney diseases are clinically distinct, let me just repunctuate this point that many disease manifestations are common. And that's important because if we're thinking about pathways that might have druggable targets, entry points to slow down the progression of the disease, understanding them in one disease might have implications for the use of these drugs, therapeutic use of these drugs in another disease. Currently in children, therapy focuses on supportive management. But as I said, I think the development of targeted therapies will require some diagnostic precision, knowing who has what underlying genetic defect, and well-characterized patients. And these are the databases for children with ARPKD and other hepatorenal fibrocystic diseases that we are actively engaged in. And just about to come online is our ADPKD database for children, for childhood ADPKD. So let me use the last slide to acknowledge so many of the people who have helped with the various studies that my group has been involved in. And I wanted to leave plenty of time for questions. So let me stop here and let Nicole take it from here to lead the question session. Thanks very much for your attention.
Thank you, Dr. Guay-Woodford. That was wonderful, and we do have quite a few questions, so I'm just going to jump right in. First, can you talk a little bit about what spontaneous mutation means to someone that is diagnosed with PKD and doesn't have a family history, and also how this would affect future generations?
Sure, it's a great question. So let's think about it this way. I love visuals because, you know, when we talk about the science, people don't necessarily have the framework to understand all the jargon and all the concepts. But I think there are some fundamental sort of concepts that we can use more commonly appreciated ways to think about it. So if we think about a gene as a tape cassette. Now, I know I'm old, and so maybe there are some people who are listening who have no idea what a tape cassette is, but I'm hoping that most people do. Let's say if a gene is a tape cassette, then you have two copies of the same song. That's the way that we're put together, two copies of the same gene. These are called alleles. And let's suppose when we're talking about spontaneous mutations, this is typically in the purview of a dominant disorder. So dominant disorders are typically in every generation, transmitted from generation to generation to generation. A spontaneous mutation is appreciated or recognized when someone shows up with a disorder that looks like dominant PKD, but there's no family history. So how does that happen? Well, let's suppose that you took one of those tape copies of a given song, and you decided that you were going to make some money on the side. So you went to your basement with that master cassette, and you generated 500 copies of that cassette. Well, most of them are going to come out just fine and play the song just fine. But if in the course of copying that tape and making a new tape cassette, the tape gets twisted, then the song doesn't play well. That is a defect in the tape that affects the song. The parallel would be a defect in the gene that disrupts the protein and causes disease. Once that happens, once a person inherits that, then that person is essentially the same as someone who inherited the gene from the generation before them and their grandparents and their great-grandparents, et cetera, et cetera. It's in their genome. And so when they go to have children, every single pregnancy for them has a 50% chance of being affected. Let me say this another way. If you have the typical transmission of ADPKD, every pregnancy has a 50% chance of being affected. So let's say that the father is affected, his father was affected, and his father before him was affected. And so the father that we're talking about has 12 children. Well, all 12 of them could be affected. It's just sort of the flip of the coin. Or he could have 12 children and none of them could be affected because he gave every single one of them the normal copy of his gene. Now let's change that father to a father who has a spontaneous mutation. It's the same principle. He could have 12 children and all 12 of those children could be affected, or you could have 12 children and none of them could be affected. So that's the kind of the concept of a spontaneous mutation, what, essentially how it arises and then how it's transmitted.
And what % of people that have been diagnosed with ADPKD are considered spontaneous mutations?
So again, a really good question. In the adult literature, what people typically write is about 5%. But I can tell you, as I talk with my pediatric nephrology colleagues, we see children whose imaging study and clinical course looks for all the world like ADPKD, but they don't have a family history. So our sense is it's maybe a little bit higher, maybe 5 to 10% of kids that we see with what we would clinically classify as ADPKD have a spontaneous mutation. Now, of course, to get a definitive number, what we would have to do is to take all children who we thought had clinical and imaging evidence for ADPKD, regardless of whether or not they had a family history, genetically test them, determine what gene defect they had, and then go back and ask, okay, is there a family member, one of their parents, who has this same mutation and thus the disease, or is this the first time that we're seeing this mutation in a family?
Okay, perfect. Thank you. Next question. Is the course of the disease for a PKD patient similar to the course of the disease experienced by the parent?
Yeah, so that's a great question. And one of the reasons that I used the baseball analogy is because actually, let me answer the question this way. Many people have heard of sickle cell disease. Sickle cell disease is a single mutation. People who have sickle cell disease have 2 copies of the very same mutation. But for those in the audience who have seen someone who is affected with sickle cell disease, or maybe a couple of people who are affected with sickle cell disease, the manifestations can be very broad. Some of them have enormous problems with pain. Some of them have minimal problems with pain. Some of them have issues in terms of having difficulty with clotting episodes, or it's not really clotting episodes, but with what's called acute chest syndrome. Other patients have no such issues. Some patients actually have major damage to their kidneys. Other patients don't have major damage to their kidneys. Some patients have strokes. Other patients don't. How could this be the case when everybody's got the same mutation? And then when you look within families, that variability can occur as well. Let's go back to the baseball team. If you have the absolute same pitcher who on Monday pitches for, this is going to hurt me to say, but pitches for the New York Yankees, and then on Tuesday goes and pitches for the Baltimore Orioles. For those of you who are baseball fans, the Yankees have the best record in baseball. Unfortunately, Baltimore this year may have the worst record in baseball. You can have the same pitcher, same talent. They probably will win the game with the Yankees because the team around that pitcher is really strong. They have a very high likelihood, given what's happened this season, of losing the game with the Baltimore Orioles. And so it really depends not just on the gene that's disrupted, but the other genes that make proteins that operate in the same pathway. And because you're in a family where not everybody has exactly the same copy of every gene, that variability in the team can come into play. So you can have a child that has much more severe disease than the parent that transmitted, that has the disease and transmitted the disease gene, or vice versa. And so using family history to predict what's going to happen with a child is not tremendously precise. The one exception to that is that there seems to be, for reasons we don't precisely understand, a family clustering of these aneurysms in the brain. And so if we can hear a family history of aneurysms and stroke in affected family members, then we worry that the child is at increased risk for developing aneurysms and therefore for developing strokes. And in that situation, we use the family history to increase our index of suspicion and our monitoring of those children.
Okay, thank you. And our next question here is, when would you start screening for intracranial aneurysms in ADPKD and also in ARPKD?
So in ARPKD, it's a handful of cases reported in the literature. It's been a matter of some debate for a number of years, but now there are reports in the literature of aneurysms in children who have the genetic confirmation of the diagnosis of ARPKD. In other words, they have PKHD1 mutations, but it's really a handful. So routine screening, no, I wouldn't do it in ARPKD. If a child with ARPKD had severe headaches or had the sudden onset of neurologic symptoms, of course I would do an imaging study of the head. I would be thinking about, could this be an aneurysm, but I would be prompted to do this simply by the severity of the neurologic symptoms. In ADPKD, as I just mentioned, I don't think that the evidence supports, either in children or in adults, routine screening of everybody with ADPKD. And that's why asking the family history is so important. So if a child has an affected uncle and an affected grandparent and an affected cousin, all of whom had an aneurysm and a stroke as a result, I would wait until they were 18 to do a screening MRA, or do it sooner if they had significant symptoms, like, for example, the sudden onset of severe headaches.
Okay. We have several people that have submitted questions about your opinion on testing children with ADPKD and ARPKD as well. So would you recommend testing siblings of children that have ARPKD? Would you recommend testing children of adults that have ADPKD? And what kind of testing would you recommend?
Great question. So we are actually in, I think, a transition period. 5 years ago, I would have probably said that if you have a index child with ARPKD who has seems to be growing normally, goes to their pediatrician, has normal blood pressure, that, you know, I would not think about screening them. I think that there was a wonderful study that was done at the NIH that looked at family members of children with ARPKD. And what they found is that in a small subset of mothers, maybe about 10% of the mothers, and a smaller percentage of the fathers, so these are the parents that are transmitting just one abnormal copy of the disease gene, there were very subtle changes in their kidney and or in their liver. They also identified in a small subset, about 78 children who were the principal in the study. A principal in a study would be called, like the term is proband. And they looked in some of their siblings and found subtle disease. In some ways, that makes some sense because, again, we said you can't necessarily predict the course of a given child based on the family history. So the bottom line for me in ARPKD is that at this point in time, I would think about having a really high index of suspicion for the siblings of a child with ARPKD. I would be sure that they got their blood pressure checked once a year. I would be sure that they got their urine looked at for protein in the urine. I don't think we have real guidelines for doing an imaging study, because what age would you do it? Would you repeat it? How frequently would you repeat it? But I think this is really something that needs much more attention so that we can sort out the guidance that we would give to parents. If we switch gears and we think about ADPKD, again, 5 years ago, most pediatric nephrologists would say, if you have a child who is at risk for ADPKD, you would watch their blood pressure, you would watch their urine for protein in blood, you would watch for the development of abdominal pain, but you wouldn't screen. And the reason is because Identifying a child with ADPKD who's asymptomatic, there's no intervention. That may be beginning to change. There is new and emerging evidence that the nature of the mutations in an individual may give information about what's going to happen to them, their prognostic course. There is information that that some children with ADPKD can have issues about blood pressure that might get missed, you know, with just kind of the typical screening sort of procedure. And there's also the issue of making a diagnosis, and this is a matter of some controversy, but I think that the conversation will go on and intensify over the coming years. Identifying an affected individual early, for example, in childhood, prompting medical intervention may, in and of itself, slow or retard the pace of the disease. So I think that it's not settled at this point. It's an evolving story. Bottom line, in 2019, if someone calls me and asks about screening a child with that has a family history of ADPKD, I still give the advice: blood pressure, growth, urine, pain. If all of those things are fine, I would not recommend it. But I am very cognizant of the fact that I may change that recommendation in the next couple of years as we learn more and more about what is the benefit of early diagnosis.
Okay, that was a great answer. Thank you so much. I know we're at the top of the hour and we have quite a few more questions. We haven't talked anything about clinical trials during the Q&A session, and we did have a few. So I thought we would end with this one. We have someone that's commenting about, can clinical trials be harmful to the participant or further progress the disease?
Right, great question. And I'm really glad that people are thinking about clinical trials. Let me just make the point that in the United States, there are probably only about 8% of patients who have various diseases are in clinical trials, and the percentage of children with diseases who are in clinical trials is even less. And those children in clinical trials are primarily children who have different forms of cancer. So we're not studying populations of patients who have these diseases to advance our understanding. And because there are all kinds of clinical trials, not everything involves a drug or a therapy. So that's the first point. The second point is that when you enter into a clinical study, whether or not it involves a drug, you really need to think about it as sort of a form of altruism. It is not intended to benefit an individual. You are one of a number of people who are participating so that we can have a number of individuals and assess their course, whether it's the natural history of their disease or their response to a medication, and draw some conclusions. So everyone who reads an informed consent about a clinical study, there is language in there that says this study may have no direct benefit to you. And that's an important consideration. There are, for drug studies, there are the possibility of side effects. There is the possibility, depending on where you are in a clinical trial, that if you're comparing two agents, that the new experimental agent won't be as good as the more standard agent. So it's not that you can, if you enter a clinical trial, you run the risk of making your disease worse. It's that if we're studying something that we don't know the outcome, particularly if there's an intervention. It could have no effect. It could be tremendously beneficial when compared to standard treatment, or it could be less than effective as the current standard of care. And so I think you have to sort of think about that as you go into clinical trials. And of course, for parents, that's a burden because it's not you, it's your child. So I think that what's important is that you go to discussions about clinical trials armed with questions, that you feel that you're really comfortable in your understanding of the clinical trial, the potential benefits, the potential risks, and that you're going in eyes wide open. You should never, ever feel, I've got to do this because if I don't, Dr. X won't want to take care of my child anymore or won't be as interested in providing the same level of care. If you have that suspicion, find another doctor.
Okay, thank you. That is all the time that we have for questions tonight. I do want to thank everyone for submitting their questions, and I'm sorry we didn't have time to get to all of them. We had some really good questions, so thank you for doing that. And Dr. Guay-Woodford, I just want to thank you as well for answering all these questions and for all of the information that you've provided this evening. The PKD Foundation appreciates the opportunity to provide you with the best possible education. After the webinar, you will receive a very brief survey. We appreciate your feedback and we will use your responses as we develop additional resources and programs in the future. When you complete the survey, please include additional topics that you would like for us to address in future webinars. If you need to reach out to us directly, please email us at pkdconnect@pkdcure.org and a member of the PKD Connect team will get back to you. On behalf of everyone at the PKD Foundation, we wish you a lovely evening. Good night, everyone.
Good night. Thank you.
Thank you. Good night.